A very good evening to all of you. Myself, Dr. Prateek Garg. So we will discuss about adenoids. We all know adenoids are a group of lymphoid tissue which are located at the nasopharynx. You can see these are my adenoids in the nasopharynx at the roof of the nasopharynx. So you can see these are known as nasopharyngeal tonsils. That is the group of the lymphoid tissue which are located at the nasopharynx over the roof of the junction at the roof and the posterior wall of the nasopharynx. You can see this is my roof of the nasopharynx and this is the posterior wall. So junction of this, these are enlarged adenoids. So let's look out what is the enlarged tonsil. Tonsils are generally present in the oropharynx, and there are some lingual tonsils also which is over the base of the tongue, and they are also enlarged sometimes. So how does a baby appear in the adenoid phases? So look at the baby. If patient is having enlarged adenoid, that will leads to an obstruction in the breathing pathway of the baby or the child. So in chronic state, suppose there is chronically these enlarged adenoid, so what are the changes in the face that will happen? Firstly, there will be elongated face. Patient will be a mouth breather, that is, he will breathe by his mouth by keeping the open mouth. Okay, and the appearance will be elongated, dull, long, expressionless face with the overcrowding of the teeth, and upper lip will be something like bowing of the upper lip, open mouth, elongated face. Nose will be pitched. Why pitched? Because of less use of this LI nasal muscles, because patient is breathing from the mouth, so there will be disuse, atrophy of the LI nasal muscles. And what are the other? There will be high arch palate. So this is the appearance with the baby with the enlarged adenoid will have. Now, what are the clinical features? Firstly, the patient or the mother father will complain that patient, my baby or my child is a mouth breather, and she or he is having stridor in the night or some noisy breathing in the night. And there will be the nasal obstruction, repeated rhinorrhea complaint, repeated discharge from the nose for the nasal blockage. And sometime baby will have this eustachian tube blockage leading to glue ear, or we can say serous otitis media. Why this happen? Because of the adenoid tissue, what happens is eustachian tube will be blocked, so there will be collection of the mucus into the ear, and further this will convert into the glue, leading to a condition known as glue ear. And there may be other symptoms like rhinolalia clausa. See, because of the adenoids, the nasopharynx or the entry into the nose will be blocked, so leading to a condition known as rhinolalia clausa. Some of the letters which we speak while use of the nasopharynx of the nose, so we can't do that if enlarged adenoids are there. And the last one is a sleep apnea. I already told you sleep apnea, the patient will have noisy breathing while the sleep. So what are the treatment? Suppose the baby is having mild symptoms. So what we'll do? We can use the nasal decongestant. We can advise if there is an infection, we can go for the IV oral or IV antibiotics. Then we can use the antihistaminic or some sort of breathing exercise. But if patient is having moderate to severe symptoms, it is better to operate and remove the enlarged adenoids. So what are the indications of the adenectomy? Firstly, nasal obstruction, that is the baby is having typical the adenoid faces because of the nasal obstruction. If these changes are occurring in the face, so we have to go for the adenoids removal. The next one is chronic glue ear. If suppose the glue ear is not getting better by the use of the antibiotics, by the use of the decongestant or the antihistaminic, then also we will go for the adenoidectomy. And what are the other indications? Sleep apnea and dental malocclusion. What are the contraindications of the adenectomy? The first one is the submucous cleft palate. So we have already discussed in the tonsillectomy. It is again a contraindication for the tonsillectomy because suppose patient is having this submucous cleft palate, so there is no bony structure in the palate, only the submucosa mucosa is there. So if we remove the adenoid, there will be hypernasality. Okay, and there will be the whenever patient try to swallow some food or chewing it or something, so it will goes into the nose also along with going into the esophagus. So that is a contraindication. Then again other contraindications, velopharyngeal insufficiency. Again, that is a contraindication which is known as aptasivant trench. Same thing, the regurgitation of food in the nose occurs in this velopharyngeal insufficiency, and if you remove the adenoids, so it will further worsen up that situation. And then acute infection of the adenoids. So you can't do the surgery in any of the acute infection because it will lead to bleeding. Okay, so and now we talk about the complication of the surgery. First complication is a hemorrhage. Then bleeding is always there as the first complication, and if you overly correct the adenoids, if you remove the pharyngeal mucosa also along with the adenoid tissue, so it will cause the hypernasality, and sometimes we may injure the eustachian tube which is in close proximity to the adenoid tissue. Then there occurs a Grisel syndrome. So what is this? It is an inflammatory subluxation of the atlantoaxial joint, or we can say C1, C2. So what happens? We do the position, overextend this, and then we remove the tissue. So because of all these procedures, sometimes there is an inflammation of the C1, C2 joint leading to Grisel